Right. Let's dive straight into this explainer. We're looking at a pretty fascinating intersection today, the clinical to coding continuum specifically for geriatric care. We're going to take the deeply complex world of older adult clinical assessments and bridge it with those incredibly strict 2026 AHIMA and ACDS query standards. So, if you've ever wondered how a physician's completely subjective conversation with an elderly patient gets transformed into an objective, perfectly compliant medical code, well, you're absolutely in the right place.
Here's our agenda for today. We'll be covering geriatric history and polypharmacy, assessing geriatric syndromes, pre-op geriatric evaluations, anticipating future care needs, and finally, compliant clinical validation queries.
All right, moving into Section 1, Geriatric History and Polypharmacy. So when we're assessing functional impairment, the absolute crucial point here is delineating between basic survival tasks and the more complex independent living skills. For basic activities of daily living, or ADLs, like bathing, dressing, and feeding, we use the CATS index. But for those instrumental ADLs, the IADLs, like managing finances, taking medications, or driving, we rely on the Lawton scale. Documenting these baseline deficits is a big deal, because they instantly signal the need for specific medical interventions or social support down the line.
From there, we have to look at what the patient is actually taking. When dealing with polypharmacy, clinicians have to screen a patient's medication list against the Beers criteria. But here's the major documentation catch. These are potentially inappropriate medications. If a clinician goes ahead and prescribes a drug flagged by the Beers criteria, they have to clearly document their explicit clinical rationale for doing it. That why is literally the core of clinical documentation integrity.
Which brings us to Section 2, Assessing Geriatric Syndromes. Now, to document these accurately, we kind of need to understand what a geriatric syndrome actually is, right? These are multifactorial conditions. Think falls, frailty, pressure injuries, urinary incontinence. They happen when accumulated impairments render an older person vulnerable to situational challenges. They don't usually fit neatly into just one single disease category. Instead, they're driven by four main risk factors: older age, functional impairment, cognitive impairment, and impaired mobility. Charting the presence or even the absence of these four factors is absolutely mandatory in geriatric preventative care.
So how do we objectively measure something tricky like cognitive impairment? Well, we use standardized tools like the mini-cog assessment. It's super fast, taking just about 3 minutes. Step 1, you give the patient 3 words to remember. Step 2, you use a clock drawing test as a cognitive distractor. Step 3, you ask them to recall those original 3 words. This is so critical because it gives us rapid, objective documentation to help differentiate, say, early dementia from acute delirium or encephalopathy.
And we have other objective tools too. The Timed Up and Go and the Berg Balance Test measure fall risk and mobility. The Mini Nutritional Assessment short form checks for malnutrition risk in under 5 minutes. You've got the Geriatric Depression Scale for mental health and the HDDA tool for sensory deficits like hearing loss. So why does all this matter for CDI? Because these tools take subjective complaints, like a patient just saying, "I feel weak," and translate them into codable, objective clinical indicators that we can actually use.
All right, Section 3, Preoperative geriatric evaluations.
It is just a clinical reality that older adults carry a significantly heightened risk for perioperative complications. Because of this, tossing a simple "cleared for surgery" note in the chart is never going to cut it. Meticulous charting of a patient's baseline functional and cognitive status using all those tools we just talked about is strictly mandatory before any surgical intervention. You have to establish a clear baseline so you can actually measure their postoperative recovery against something concrete.
Moving right along to Section 4, Anticipating Future Care Needs.
Getting advanced directives confused is a massive liability. It's absolutely essential to correctly document the distinction between a living will and a healthcare power of attorney. A living will dictates specific medical interventions like ventilation or hydration when a patient loses capacity and is terminal. A healthcare power of attorney, on the other hand, simply designates a proxy to make decisions when the patient lacks capacity. And remember, this is entirely separate from a financial power of attorney.
Along those same lines, our documentation has to clearly delineate between palliative care and hospice care. Palliative care manages symptoms concurrently with curative treatments, meaning the patient can still be actively fighting the disease. Hospice care focuses exclusively on end-of-life comfort, initiated only when curative treatments have stopped entirely. Mixing these up in the chart fundamentally misrepresents the patient's entire care plan.
Finally, Section 5, Compliant Clinical Validation Queries.
Let's bring all this together. Imagine this scenario. An elderly patient comes in with a 14-pound weight loss, a recent fall, and confusion. As a CDI specialist, you see the clinical indicators right there. But how on earth do you query the physician for malnutrition or dementia without illegally leading them to the answer?
Well, the answer is found in the updated 2026 AHIMA and ACDIS guidelines. They state that substantial compliance relies entirely on clinically sourced indicators. The query has to completely exclude any references to reimbursement, denial mitigation, or quality outcomes. The provider needs total freedom to exercise their own independent clinical judgment. No leading allowed whatsoever.
Let's look at what this means in practice. A compliant query has to remain entirely objective. You can never insert your own subjective interpretations. So if the chart says the heart rate is 120, you quote heart rate of 120. You do not translate that into the word tachycardia in your query. You literally just pull direct quotes, exact lab values, and scores from those objective geriatric screening tools we went over.
Now, one of the biggest updates in the 2026 standards involves prior encounters. Yes, you can leverage prior encounter data to establish baselines, like a previous diagnosis of cachexia. However, here's the catch. That old record cannot be the sole basis for your new query. You have to have sufficient supporting clinical indicators present in the patient's current admission to justify asking the question today.
When you're framing your queries, the format dictates the rules. If you're using a multiple-choice format to clarify a diagnosis, you must only offer clinically relevant options supported by the chart. Plus, you always have to include an unable to determine choice. Yes/no queries are much stricter. They're only used for already documented diagnoses, establishing present on admission status, or confirming cause and effect. You can't just use a yes/no query to fish for a brand new diagnosis.
Also, a really helpful tip: embedding standardized diagnostic criteria directly into your query template is highly encouraged. For example, if you're querying for protein-calorie malnutrition, pasting the Aspen criteria right into the query is perfectly compliant. It gives the physician a solid reference point without ever indicating a preferred answer.
So ultimately, the goal of understanding this whole clinical to coding continuum boils down to one question. Are we capturing the true complex vulnerability of our geriatric patients through rigorous, objective, non-leading documentation? Because when we do exactly that, the patient gets better care and the whole healthcare system functions with true integrity.
Please like, share, subscribe to Decode Healthcare with Harshal.